Hotbed Talk.
I'm honored to introduce Sarah Ruane. Sarah is currently Sports England's national lead for health, and she led extensive transformation and investment programs in preventative health.
I'm jointly chairing this session with Stefan van Rooijen. I hope I said your name right, Stefan. And it's a great pleasure to introduce John Moore, the head of Division of Anaesthesia and Critical Care at Manchester Foundation Trust, but more importantly, the clinical director for cancer prehab and rehab in Greater Manchester. And those of you in the UK will be aware of the big political changes that are going on in Manchester and the opportunities they have up there. Anna Lowe, I think I'll get her roles right, is currently Programme Director at the National Centre for Sports and Exercise Medicine in Sheffield.
And it's Dr. Graciela Martinez-Palli from Barcelona. And she's a consultant anesthesiologist at the hospital clinic in Barcelona. But she's a lot more than that. She introduced prehabilitation in Barcelona from 2013. She has worked on programs for patients with major abdominal surgeries, and she expanded the program to many other surgeries at this moment.
I'm going to jump ahead of Slido and just ask one question, which is, so with prehab, we are typically dealing with secondary and tertiary prevention, people who've got established deconditioning or chronic conditions. But how do we link that with the primary prevention, or how do we solve the problem before it even happens, or is that something that we should be getting into? John?
I think we should be right in that space. And there's a massive opportunity with public health funding that's coming down. We've got a project in Manchester called GM Moving and similar projects across the north where these funds could be utilised for patients in the 40 to 60 year age, which are often males who don't exercise. And they're the people that in the future will have cardiovascular and cancer complications. So we think we want to work with that group, and also the people that are reflected out who don't have cancer. So that 90% of people that have a negative diagnostic, they would be a perfect group to do that primary prevention, and that's what we're going to look at across the north. I think it's what we should focus on.
Just to build on that, I guess I've found over time that we sometimes unhelpfully talk about is this project about prevention or treatment, and always have to encourage other people to step back from that and say it could be both. It doesn't really matter at the end of the day. It doesn't. A lot of the time, it's about secondary prevention or tertiary prevention, and it's more about patients or people having the support to be as healthy as they can be, and irrespective of at what point they've accessed primary or secondary care.
It ties in very much with making every contact count type approaches. So those some of that advice around healthy lifestyles is embedded in prehab programs, but for people that don't enter those programs, making every contact count is a much broader program that health and social care professionals are encouraged to engage with all their patients. So I think there's a real link there as well.
So there's probably some thinking that we as anaesthetists and more broadly need to be thinking about every time we meet a patient, talking about not smoking, not drinking, getting more active for next time we meet them.
Yeah.
Stefan.
Sarah, we have a question for you. It was recently suggested that GPs prescribe physical activity, and that there was outrage on social media that it was not their job or considered their job. So how should we change the mindset of those GPs?
I guess I would say it's a combination of things. So one is, I mentioned about the undergrad curriculum. So it's how do we actually change the culture so that physical activity is just seen as part and parcel of the job, and some of that will only be possible over a longer period of time, and around supporting those that are currently being trained, so it just becomes the new normal. I think it's providing healthcare professionals with, I say GPs specifically, but all healthcare professionals with as much support, resources as possible, but in a usable, digestible format. And Anna mentioned it in her presentation that sometimes that's just really simple messages. We're also looking at doing some work with a number of the Royal Colleges, the General Medical Council, and also the Defence Union on the common barriers that are being flagged around physical activity and risk. And I think it's often less that GPs feel that it's not their job, it's more that they are up against it. There's a lot of competing priorities. So it's how do we make their job as easy as possible and raising physical activity become really seamless. So we're working on some of those kind of big, I'd say, system policy blockers that make it harder for GPs and all healthcare professionals.
I think that in every country could be different, but in Spain, for example, the primary care is really focused on improve this kind of programs. But what happened there is that when the patients go to the hospital to be operated, then it's like if the line breaks, and then the primary care physicians, it's only on the other side. So even sometimes give to the patients message that are not really good. And for example, I had the experience sometimes that is the primary care physicians who say to the patients, you are going to be operated, so take care, relax, don't do anything, and just prepare for the surgery and relax. And that's why I think it's really important, the communication between us and the primary care, because for at least in Spain, they are very engaged with these physical activities.
I think the other thing to say is that we've been tutoring, if you like, our surgeons to say, you have to say to the patient that exercise, it's an intervention of itself, it's medicine. If we say prehab is right and we want to do it, then we need our surgical colleagues to say, this is part of your care. We heard that very eloquently yesterday from a team in London to say, well, and if the surgeons say it, it's part of your care. 3 times a week you will undertake this intervention, this medicine. If we agree it's medicine, and that's do we all agree it's medicine? Yeah. But it will happen. And the surgeons in our area have said, okay, we'll say that to people. And you've got 100 plus surgeons across GM saying, okay, we get it. So I think it's, the GPs are very important, but I think that particularly for cancer, the surgeon and the oncologist are so, because that person will save that person's life. And that relationship isn't the same as the relationship that we have, I don't think. So I think we need to get them to do that for us.
When I look back at my med school, there wasn't anything about prehabilitation or the importance of exercise or nutrition. But as a doctor, I didn't know anything. So I think it is a brilliant suggestion that we should incorporate all this knowledge, raising new doctors and nurses about the importance of this.
I think we're properly getting the hang of Slido. This is undoubtedly the most popular question so far, with 30 votes.
Wow.
I'm afraid it's a very British question. So how can we get people to exercise more or lose weight when Boris Johnson... Graciela, you just don't want to know about me. You don't know about it already. Somebody to move the question. But when Boris Johnson is advocating getting rid of sin taxes and avoiding the nanny state, so almost the anti-argument to health promotion, what do we think?
As an arm's length government organisation, I have to be very careful about what I say. I guess I'll take the bit around nanny state. We're doing quite a lot of work in consulting with people, real people, which sounds very obvious, but it's amazing how many times it gets missed. To really understand what messages best resonate around physical activity. And it is very much any message coming from government, public health type, traditional public health type messages don't land quite as well, because it feels like they are being told what to do. It's prescriptive. It feels they're trying to be sold something. And we have found who the message comes from is really important, hence why we're working with the health charities who we know are trusted by those individuals. And then how that message is given is really important as well. So it's not about prescribing and telling, it's about supporting, it's about offering advice and empowering people to feel that they can make that choice themselves and they have the right support to then make changes to their own lifestyle. I won't pick up the Boris bit.
I think the other thing is when we say to people, like, for instance, stop smoking. Stopping smoking is a really hard thing to do if you've ever smoked. And we say just go away and do it, whereas I think we have to give patients a solution to help them do that. And there's a cure programme in Manchester, you may have heard about it. It's trying to reduce smoking across a population, similar to what they did in Ottawa in Canada, which is an amazing project. So we're trying to do that in GM, and that's giving patients in secondary healthcare Champex and other nicotine replacement therapy as they land in hospital. So I think we can challenge people, but we have to give them a solution to help them achieve that, particularly psychological. And the other thing, if you saw it in the Times today, obesity is now overtaken smoking as a leading cause of cancer in the UK. And that's very worrying. But if you look at those, I could show that deprived areas of the UK. On top of that, McDonald's, if you look at it, and fast food exactly replicates that. So as a government, I know what Boris Johnson is saying, but we have it within ourselves to help obesity. But we have to give patients support to how they do that and let them see for it. It's about education of the patients as well, I think.
I did wonder the Boris Johnson thing with a kind of reverse psychology on the basis that most of the country don't believe what he says, therefore it must be true. Stefan.
Okay, so the next question is about money. And I'm the lucky one presenting this afternoon about money in business cases. However, I don't know the business case of the NHS. Does anyone? Why would they invest £1 million in this program and prehabilitation?
The way that we've pitched it is well, actually no one knows the true cost of cancer when you look into it. There's estimates about how much it costs. So we're now trying to figure that cost out in GM. How much does it cost through the whole system? And then we are going to utilise that ability to understand the primary and secondary care episodes over the next couple of years to help us design the savings within the system. And I think if you just looked at length of stay, it's probably a difficult thing to budge. But actually, if you look at the ongoing cost to health, that's where we'll make the difference with prehab. So we have to make it business as usual, but we're borrowing from colleagues like Southampton, as I mentioned, and others from their research for us to make it such that in 2 years' time the evidence will be there to support it. So, but it has to be affordable, just to finish on that. So that's why I would suggest there's a universal offer and there's a more high-cost offer, if you like. And the universal offer for me could be very cheap. It could be around £100 to £150 per patient, which would include free gym membership and digital technology. It could be as simple as that for the majority of people, but as you go up, then you're talking £500-600, as you were quoting before, something like that.
So there is a big belief that it will save us lots of money on the long term, but there isn't an exact business case yet, or is there?
We're having to try and answer the questions, all of that. We're trying to affect all parts of the system, so length of stay, complications, and eventually 2 years survival. Our big thing is 2 years survivorship. And if you ask patients, they don't really care about length of stay. They care about, am I alive at 2 years with good functional recovery? So I think we have to move the conversation to that and not be too stalled by this bit.
If I can just add, I think from an NHS England point of view, I think there's a huge amount of interest in the work that's going on currently. People are watching very, very carefully as the evidence base builds in these, pragmatic trials and projects that are going on. I think NHS England is committed to other big programmes of work and works around business planning cycles, but that door is very much open as in the future and as the evidence builds.
And just to add to that, we're trying to really make sure there is that economic case for physical activity, and as in lots of other partners are doing a lot around return on investment. There's one I guess part of it that I always come back to, which is a lot of decisions that are made, I mean, from my experience locally, aren't necessarily about return on investment and whether the business case is solid. Some of it is also around kind of almost the storytelling, so the compelling case of the impact that this intervention or this piece of work is actually having on people and the community. So I think it needs to be, so the question was, what is the underlying business case? It needs to be a combination of, what are the kind of hard facts in terms of return on investment, bearing in mind that often right now people are looking for cashable savings in year. So what can we do to really shift funding from, I'm saying it now, treatment to prevention. But what can we do? And some of that is actually about telling a really compelling story around the real life impact as well as the business case from an economic point of view.
Mm-hmm. Brilliant.
I like just only ask that I think that our problem is that perhaps sounds really good. Our intuition is that it's really, really good, but it sounds very poor, sophisticated. If the treatment was with a name like robotic or immunomodular or some molecular treatment, then maybe the investment were greater. But it's so simple, so easy that nobody thinks that if it's not saving money, we can implement that. It's kind of.
And I think that's where CPOC is going to become really important, Mike, because the political agenda in the UK I'm looking at you, but to influence how the government views that. Because if a trust says I want to spend £1 million on a robot, how do we find the money? It's almost abhorrent in a way, isn't it? How the system is designed.
Mm-hmm.
Brilliant. Regrettably, we are out of time. And just to close, if you would join me in thanking our fantastic speakers for a great session.
Jerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.